Ptosis is a Latin word that we use to describe droop. You could talk about droop of the oculi, and that's a form of ptosis. You could have a droopy eyelid, that would be ptosis of the eyelid. In our case, we're going to discuss ptosis of the breast. There are several categories of ptosis of the breast. The first is pseudoptosis, where the breast tissue hangs below the inframammary fold, but the nipple and areola are above it. First degree ptosis is when the areola is below the inframammary fold, but the nipple is above the inframammary fold. And the inframammary fold is where the breast hits the chest wall. When the nipple is at, or just a tiny bit below the inframammary fold, that's second degree ptosis. And when the nipple is pointing at the ground or is significantly below the inframammary fold, that's third degree ptosis. Pseudoptosis and first degree ptosis can be dealt with very simply by putting a slightly larger implant in. That's number one. Number two, if you have the nipple at the inframammary fold or just a teeny bit below it, very often you can deal with this by doing what's called a dual plane mastopexy, and I'll explain that in a second. If your nipple's pointing at the ground and you have third degree ptosis, then you definitely want to do a formal lift of some kind. You can't just do an internal or non-scarring procedure. You need to make some cuts in the skin, take away some skin, and reposition things. The breast surgery that we mostly do after pregnancy is just a breast aug, straightforward breast augmentation, or dual plane mastopexy with breast aug. So let me take you through the standard breast aug. Most women, the majority, lose volume from their breasts, but their breasts don't actually droop. And so these people are deflated. They're not droopy, they're deflated. They sometimes come in saying they're droopy, but when we look at the position of the inframammary fold, where the breast hits the chest wall, and the nipple, you realize that they're not droopy, they're merely deflated. There are multiple ways to put breast implants in. You can put breast implants through the armpit, you can put them around the areola, you can put them through the belly button, you can put them through the bottom of the breast, and you can even put them through the edge of the nipple. I've tried all of them. I find that there are only two of any merit for me. If you're in a really tight situation and you need to find a way to get an implant in for unusual cases, the edge of the areola is a very, very good way of doing a breast augmentation. However, my favorite way, and the way that leaves the least amount of scarring, is when you go through the armpit, and that's known as transaxillary. Transaxillary means through the armpit. Secondly, you can put the implant above or below the muscle. I definitely believe that 99.9% of the time you want to put the implant below the muscle. You get a better mammogram, you get softer breasts, you get a more natural look. It's definitely much superior to above the muscle. I'd like to take you through breast augmentation and give you my understanding of the entire scope of breast augmentation. The different routes of entry, the different positions, the different styles of implants, and so on. There are two manufacturers, Allergan and Mentor. Both produce very good products. There are saline implants by Allergan and Mentor. The saline implants were used almost exclusively from 1991 till 2006 when silicone came back on the market. I'm not a big fan of saline. One, when you sleep on them, you think you're sleeping on a waterbed under your skin. Two, they show rippling, which very often looks just terrible. Three, they have a valve, and valves tend to deflate. So in general, I like silicone better than saline. Silicone has been shown to be completely safe. The FDA took it off the market in 1991 and put it back in 2006, and they did rigorous testing on everything, and there have been very many good studies to show that it doesn't cause any collagen vascular disease like lupus, and it certainly doesn't cause cancer. So the next area after saline versus silicone, you want to talk about the covering of the implant. There's two coverings. There's smooth and there's textured. Kind of sounds like Skippy peanut butter somehow or other. Well, I don't like the textured implants. The textured implants came out in the early 90s, and the theory was that they would stay softer because scars wouldn't line up, scars would be around each little bump. And unfortunately, you get scars around each little bump, and then you get a bigger scar around the entire implant. So I feel that smooth implants stay much softer than textured, and some very good authorities agree with me. The next area to discuss is whether you want round or teardrop. I put in 50 teardrop implants. I took out 50 teardrop implants. The problem is they're dimensional. They have to sit a very specific way, and when they don't, there's a serious problem, and they rotate and they turn diagonal, and no one has ever thanked me for a diagonal breast. So I do round, smooth implants. I do not do teardrop, and I do not do textured. The next area is how in the world do you put them in? Well, putting implants in through the belly button, I think, was invented on a dare, and I dare you to do that. And a guy in Cleveland came up with it, and it's very clever, but it makes no sense to me at all. You don't have the ability to really be sure that the implant's sitting just the way you want it, just where you want it. Also, you can only put in saline implants, so I'm not interested in that at all. Inframammary, below the breast, was a way that was invented in 1963. It's very basic. The scars are not good. At best, they're fair. And you don't want to go get a massage or go to the gym and have everybody find out you had implants. So I don't like that way at all. Around the edge of the areola is a good way in certain very, very specific conditions. But in general, a scar on a breast really ruins the basic appearance of a breast. And no matter how good the surgeon is, the genetics of the patient may give you a not good looking breast. The next way you can put it in is right at the edge of the nipple. And again, you can only use saline, not silicone. But on top of that, you really don't get the ability to see exactly where you want to put, to get the implant exactly where you want it. Therefore, I'm not interested in that. Going through the armpit is my favorite way of doing it. I've been doing it since 1989. I feel very comfortable with it. And there's a lot of rumors out there that you lower the fold more than you want to, or, they're tricky. I agree. There's a long learning curve. It took me probably 4 months to be absolutely sure that I've done this just the right way. But now, 3,000 breast dogs later, I feel very comfortable with going through the armpit, underneath the muscle. And that leads into the next. Do you put it on top of the muscle, or do you put it underneath the muscle?